Our first speaker is Oliver Ehrt, Professor of Ophthalmology in Munich in Germany, and he's going to talk about eye muscle tendon elongation, what you can do when you run out of enough muscle to move the muscle back as far as you want to. Oliver, thank you very much.
Welcome to a short talk on muscle tendon elongation, which is one way of weakening a muscle, something we very frequently do in strabismus surgery. We may use it as a one muscle procedure or bilateral weakening procedures. We may use it in combined surgery, and weakening a muscle is mandatory in restrictive strabismus and in congenital dysinnervation syndromes. Here we have an example of a patient with restrictive Graves' orbitopathy. There are some limitations when you weaken a muscle. One is the arc of contact. For example, on the left side, you see a normal muscle. When the muscle contracts, the eyeball rotates, but the muscle force is still maximum to rotate the globe because it's perpendicular to the surface of the globe. Whereas if you have a recessed muscle like here in the middle, you will see once the muscle is in action, the muscle loses contact with the globe, and now the muscle force is no longer tangential to the surface of the globe, and only this part of the force is working to rotate the eye. So you get a limitation of motility the further recessed you have a muscle. This can be avoided by not attaching the muscle to the globe, but elongating the muscle and attaching it at the original insertion. Now, again, the muscle force is transmitted perpendicular to the surface of the globe, so you have maximum adduction forces acting on the globe. There are other limitations when you weaken a muscle. One is the interaction with the pulleys, which occurs when the muscle is more than 10 to 14 millimeters recessed, weakening the effect of your recession, and the overall shortening of a muscle is limited by the sarcomere shortening. So again, when you get more than 13 or 15 millimeters, the muscle cannot get shorter anymore. When you do muscle elongation, the arc of contact, as shown, can be improved. However, elongation of the tendon does not reduce the effect of interaction with the pulleys or sarcomere shortening. So how to elongate a muscle? There are many different techniques. The most simple one is hangback sutures, which I don't do anymore, which I don't like because the reattachment of the muscle is less predictable. And so I prefer a fixed amount of recession or elongation. There have been several artificial materials used, silicone, Gore-Tex, Mercilane, but they may cause permanent foreign body reactions and conjunctival erosions. You can use fascia lata, but again, this makes the surgery much more difficult because you have to retrieve the material, and you may have muscle reconstruction, Z-plasty or other techniques, which may be, just elongates the muscle, but makes it much slimmer. And my preferred way of muscle elongation is using bovine pericardium, which is commercialized under the name of tutopatch. I do not have any commercial interest in this product. It's bovine pericardium, and it's processed to remove cells, pathogens, any bacteria or virus which may be in the pericard, and then it's dehydrated so it can be stored under room temperature. And once you use it, you put it into saline solution, and after 5 minutes, it's flexible and can be used for your surgery. It is replaced by connective tissue of the body, the patient, over weeks, and gives an appearance which after a while looks just like normal tendon or nearly normal tendon. The advantage is that it gives a very well-defined reattachment of the muscle, and so you have a defined elongation of the muscle and recession if you want, and there are no adhesions from the tutopatch with the sclera except at the location where you suture it to the sclera. So it can easily be revised and does not cause a lot of scarring. So what are my surgical steps? Here I have a muscle which I want to recess and elongate the tendon. I take a patch of, a stripe of tutopatch which is just the same width as the muscle. I attach it with with resorbable sutures can be used, and I detach the muscle and let the muscle slip back. Then I reattach the tutopatch to the sclera with a recession and muscle elongation, which gives me the total effect of my surgery. Afterwards, I just detach or cut away the anterior part of the tutopatch. As I said, resorbable sutures can be used because the tutopatch will be resorbed and replaced by tissue of the patient. Why do I use a recession on top of elongation? First, I have less bovine material in the patient afterwards, and I often have to recess the conjunctiva as well, and I want the new insertion to be covered with conjunctiva. So a recession combined with elongation is most useful. Most of the time, I do use tutopatch elongation in revision surgery. So the muscle is already recessed, often quite far away from the limbus. Again, I take my tutopatch, attach it to the muscle, I let it slip back further, and then I reattach it a bit anterior to the last insertion I had, because often it's far away and I want to have a good arc of contact for my tutopatch new tendon. So I have an elongation. My net elongation is calculated by the size of the interponad subtracted by the advancement which I use. There have been a lot of studies and research presented, which I had shown on the previous slide. Often I do a recession and elongation or advancement and elongation. The maximum of recess and elongation should not exceed 13 millimeters because you will get adduction deficit due to the shortening of your sarcomeres and interference with the pulleys. The effect is difficult to predict. On average, there are 2.5 to 3.5 prism diopters per millimeter, but the effect is very variable and it does cause some limitation of motility. Here is a dose response curve presented by Uvenhaus from Essen in Germany. And I will present a patient which I operated, a patient with Graves' disease who has a severe limitation of elevation of the left eye. So this is in primary position and up gaze. In side gaze, you see especially the limitation of elevation in abduction, typical of Graves' disease. So what I did in this patient was an inferior rectus recession of 4 millimeters and 10 millimeters muscle elongation. And this gave a very satisfactory result. In primary position, there's orthotropia with a mild hypophoria of the left eye on cover testing. But the patient could fuse this small residual deviation, and elevation now is possible beyond midline, but still limited. And down gaze is very well preserved, but slightly limited. So this patient had a very successful result. So this patient ended up with a very nice field of binocular single vision, allowing 10 degrees of up gaze and 20 degrees of down gaze. So when to consider elongation? Most patients do have severe restrictive strabismus like Graves' disease. I sometimes use it in dysinnervation syndromes, fibrosis syndrome, to elevate both eyes. I don't use it in Duane's because it has been reported that it does reduce the adduction of the medial rectus muscle if you use tutopatch here. I prefer transposition in Duane's if necessary. You can use it in paralytic strabismus. I advise to use it most of the time for revision surgery, because when I use elongation surgery as a primary procedure, I had some over effects and severe limitations of motility, so I have returned to use it for revision surgery only. You can use it if the patient refuses surgery on the sound eye and you have to get more effect on the already operated eye. And you may also use it if you find very abnormal sclera posterior to the insertion, so you can reattach the muscle to the original insertion using the tutopatch. So as a summary, I keep this slide and I'm happy to take your questions. Thank you for your attention.
Oliver, thank you very much indeed. That was very interesting. One point that you made was it is very variable in its outcome. Have you tried using it with adjustable sutures? I mean, is it feasible to use it with adjustable sutures?
I don't believe in adjustable sutures because the adjustment, yes, the adjustment must be done the day after surgery. And often you get a very variable adaptation even weeks after surgery, especially in Graves' disease. So I have seen significant improvements. And if I had adjusted, I would be worried to get an overcorrection too early. So that's why I don't use adjustable sutures.
Oliver, have you ever used it in congenital fibrosis syndrome, where you have a very, very tight inferior rectus in children?
Yes, as a second procedure. So they had previous recessions, long distance, and it wasn't enough. So I put in a tutopatch and it gave quite satisfactory results. No motility, but the chin up position was gone.
Yes. And how expensive is this tutopatch?
It comes in different sizes, and we need a smallest size usually, and it's around 100 euros.
Okay.
And you can use it for both eyes if you do bilateral surgery.
Yeah. And no questions about prions and mad cow disease from patients?
There has nothing has been reported, and the company keeps the process a little bit of a secret, but they promise that all pathogens are removed, and I couldn't find any report of transmitted diseases with a tutopatch.
Yeah. How often have you reoperated on patients who've had tutopatch, and what did you find?
Sorry, reoperate. Perhaps I had 5 reoperations, and it was quite easy to revise. I was quite amazed. I was expecting more scarring, but actually there's very little scar in it, and it looks like nearly normal tendon. And the earliest I have gone back is after 3 months already.
Thank you, Oliver.
Welcome.
And